And also there is CMEs for this, and so you'll get that for every time you attend. And I'll figure out how to put the link into the chat. And once you get your UVM ID, if you don't already have one, once you create that UVM ID, it's actually not hard. Once you do it the first time, it's kind of a little bit clunky, but once you get it, it's very easy. And you could even do it at the end, and you just click off the 6 or 5 sessions that you came to, and you'll get a printout if you need to submit your CMEs. So you will get them. But you have to claim them within 30 days. I guess that's what Kelly said, right? 30 days, but I guess don't lie to me about clicking out at the end. But I think you can. But anyways,
we should be through these in 30 days, and there's some wiggle room there before but they do ask that people claim in 30 days. They stay in the system longer.
Yeah, so even if you do after 3 times and just do it, but it's once you get your UVM ID and you drop down, you figure it out. It's not too bad. So anyways, you get credit for this. So thank you for attending, but we also want to make sure you guys get credit and use that to support your CMEs that you need to get.
If you're interested in getting CMEs, if you'd put in your email address, then we can actually reach you with those instructions. Just add that to the chat. I'll put a note down that down here in the chat as well.
Okay, so today's objectives is we're going to, sorry, I'm in a working office, reinforce skills around the delivery of guideline-based asthma and self-management education to support asthma control. The whole point of this is to focus on getting the kids with asthma. Oh, sorry. Wait, but quite loud. So we're just trying to support kids with asthma be in better control. That's kind of the point of that. So what the whole goal is for you to identify children who are not in good asthma control and try to pick up a few of those kids and in your school and topic, and so you can clump them all together and work and do the program with them. We have tools to monitor, so that's clunky and annoying, but the rest of it is really straightforward. And we ask that hopefully you can deliver it to at least one student and share the workflows as well. So these incorporate the 2020 new asthma guidelines. And then another thing we're going to talk about is the Envision walkthrough, and that's through the Department of Health, and as well as if you kind of, do the vision walkthrough, which you'll learn more about, and you do the one student through this ASME, and then you nominate your school for asthma-friendly school recognition, which is really great. Your school gets money and you get recognition, and you can use that money towards stuff for your asthma or nursing program or whatever you want. So it's kind of a nice, easy, low-hanging fruit to get some little bit of extra money for you guys. That's the objectives that we're hopefully going to get through. This is kind of the layout of each kind of the 4 sessions of the ASME kind of layout. And we'll do that. So kind of like what is ASME, filling out the section and kind of getting through the yucky stuff of like the data. And then after that, there's one of like how to use your medications, how to use devices, and using the ACT questionnaire, the asthma kind of scoring. Then there's another session on triggers and reduction, and that's a really good one for the kids to kind of work through. There's a little like, what's in your house type stuff, and the kids will you can help them identify and maybe help reduce a few things in their house, like don't let the cat sleep on their head, kind of some stuff to reinforce that with the kids, and they'll hopefully hear that and want to get better and try to bring some information home to their parents. So that's one session, and just like the other one is like daily management, how to work with it, how to help you, and kind of checking your inhalers, and kind of just some education for the kids to learn. It's amazing how well the kids are receptive, and especially school-age kids, they want to get better, and they bring it home to the parents and kind of help make some small changes, and hopefully that can make a difference for them. And then you have the annoying stuff at the end that Karen loves, all that data.
I believe.
And so it's not too bad once you get through it all. It's a lot of check boxes. They've really tried to streamline it to make it so it's not so hard. but kind of just checking off the asthma questionnaire again. You can have the child, if they can read on their own, they can do that independently and kind of just check it off, and then you can just score it that way. So that's kind of a quick overview of asthma, and we'll get more into it. And we have videos to go with it, and there's a kind of a whole little program. So you could set them up with an iPad in your office. And if you have another child coming in and need to be, I know everyone's really busy. So that's kind of asthma in a nutshell. And then I think the next one is we're kind of going over the session 1 of kind of what it is, how to teach it, kind of give you more intel on, kind of dive in a little bit more into the program so you guys can better understand it and be able to teach it. I think this is pretty self-explanatory. I'm going to pass it off to Karen, but we have a lot of asthma in Vermont.
Yeah, thank you, Melissa, for getting us started. Well, yeah, we have a lot of asthma in Vermont, and thank you for giving that intro to the sessions that we'll be having, and to talk about the asthma prevalence. I mean, you guys are the frontline workers, so you see its impact in your schools and amongst your students, but the challenge is real. It's pretty big. We've got a lot of adults. We're top in the country, top 5 states with the highest asthma rates, and so a lot of families are impacted, with about 1 in 8 adults and 1 in 12 kids. We have even greater burden amongst certain clusters around the state. Those with low socioeconomic status, lower educational status, those who are Medicaid insured, which is related to economic status, and those who are living in older and poorer housing stock, or renters, multi-unit housing, and certain locations like maybe near roadways or busy transit roads where dust is big. They'll have even higher asthma rates, and or symptoms and or exacerbations. So we see regional hotspots. We see problems with kids who are exposed to secondhand smoke, or individuals with asthma who smoke and vape, which we also are top on the list. And then, of course, there's issues related to, families in certain occupations, farming, for example, farming families, or others, those with disabilities and other co-occurring chronic conditions, and those who are unable to work or working at home, related more to adults there. For the implications of that, and you probably see it, but some things are a little more subtle. We see that, yes, in the 1 in 12 or 9,000 kids who have asthma, we see at any one time, no matter how good our healthcare system is currently, there's about 61% of Vermont who report having uncontrolled asthma. So that's a lot. They're just living with, asthma that's uncontrolled. And so as a result, you also see with that 1 in 3 kids who've missed at least 1 day of school in the last 12 months. You see, this part makes me sad, is the 1 in every 2 kids, so 50-50 chance that a child will have an activity limit in the last month, and 1 in 6 who are not getting the sleep they need. They're being disrupted due to asthma in the last month. And then you've got all those taken together, means that about 51% of the kids with current asthma have had an exacerbation in the last year, and has put them at greater risk of having an asthma-related hospitalization or ED visit, which can be costly, keep them out of school, etc. So some of the things that are indicators of uncontrolled asthma, on the, starting with the emergency events, are at least 1 ED visit or urgent care visit or hospitalization in the past year, 2 or more a year primary care office visits for asthma symptoms, 2 or more asthma control tests, There are a variety of tests you're familiar with, probably ACT, AHAC, TRAC, various kind of tools that allow you to assess objectively asthma control, 2 or more of those. Greater than 1 course of oral steroids, and then other things that you're more likely to see, reoccurring visits to your office, frequent use of albuterol, other kinds of things. And we know that things that can cause flares include exercise, play, excitement, stress, extreme cold and heat, allergies, air quality things like one that school nurses often face in schools is the use of fragrances and scented products throughout classrooms, usually. Even essential oils, which can be problematic for some kids, and other common and personal triggers. So we're leading off this conversation with saying there is this approach, this best practice approach. It's called best practice because it's been research tested, that if you give this more supplemental education that covers those 4 topics that Melissa described, they can produce improved asthma control that can be sustained over up to 1 month, 6 months, even 12 months. It's been measured. So the issue is how to get that extra education to those kids. It usually has to be done in 2 different educational blasts so that the brain can take it in, or you can process information. And who can deliver that, and how can it be delivered easily? So one of the things we did with Dr. Cowan, Melissa, working with us at the health department, is to develop these brief videos. They're all about 5 minutes long, that cover these 4 topics that are guideline care topics for this intensive asthma. And those we've already discussed, but cover your basics, your medications, triggers, and daily management. And these are available to you if you were so inclined to try to help out a kid who's had a persistent issues with uncontrolled asthma. And so we also have some versions that are in Nepali and Somali, and are working on trying to increase the number of languages they might be available in. So what kinds of things would you do? We're trying to see if you can identify at least 1 student now, and before we're done with these sessions in a couple of weeks, that you would begin to, if not complete, 2 sessions that would cover these 4 topics with your kids. We expect that each session and topic would be about 5 to 10 minutes. When they come into your office to get your medicines, you could do a blast. And complete all 4 topics in 2 to 4 sessions. And so the trick really is trying to identify and then do a quick assessment. And this is where Melissa said that I'll do this little annoying element, which is it's helpful if you can actually track it on a piece of paper, so that then you can look at the results a week or 2 later and actually track. And if you do 2 or 3 kids, you can not mix up the progress that they're making. So in other words, to identify your kid, get them scheduled to come in and see you, or figure out your way you're going to do it. And then by the end, have some way of tracking and recording that. So I sent many of you a packet, an Ask Me in Schools packet. I don't know if you haven't received that, put in the chat your I need a packet and your email, and I'll get you a packet. And so, but basically it includes doing a quick assessment. You look and have them run through the ACT test, is one of the tools we're using as a fast way to get an objective assessment of their asthma control at that one time, and then do a quick check of, are they doing a device? Can they use the device properly? This is one of the most significant reasons asthma medications aren't getting to the lungs. Either they're not taking their medications as prescribed, or they're not using their device properly so that the medicine can actually get to their lungs. So just a fast, quick check. And then if they're not doing it properly, to do a quick coaching of what that would be like. And this is tricky because, of course, always the devices change or they're different for each kid. So you've got, to find maybe links or whatever to how that device should work. But it really just means filling in this short 2-page form is a 2-page form plus a follow-up form to see if there's sustained control. But the top portion is some basics of why you noted them as uncontrolled. Then it gets into a checklist of, it's small here, but I can, let me see if I can find the actual big version. So basically it gives you, this packet has like a checklist approach to the content. So this actually serves as your own curriculum and you don't need to use the videos, or you could use the videos. And then it kind of shows you the actual steps. So it's kind of like a guide to it, but then it gives you the forms. So the first form is just your school information, de-identified student information, because I don't want to be knowing any of this information, but just kind of be able to track the kid, but using their initials and their age, and then why they were uncontrolled, any elements about that. And then your assessment, your first assessment, and what their asthma control score was, and what whether it came out as controlled or uncontrolled, and then do they do proper demonstration. And then you give them some of the content, either through the videos, 4 videos that cover these topics, or through this checklist up here of content. And you go through, what are normal lungs? What is asthma? Most of you know all this content anyway, and can share that off the checklist, but then really providing any reinforcement like how to use that device properly. And then at the end of, once you're finished completing that content, which is usually like the next week or the week after that, then you can just do a quick assessment again. Ideally, if you could do that assessment after 1 full month, then you can get a real good post-assessment. And then 1 full month after that would be, well, actually, you can do any 2 weeks. You can do an assessment, and then 1 full month after that first session, you can do a 1-month check. And then if they're sustaining control, that's great. And it really asks you the same 2 questions. What's that asthma control, and are they under control? And then you just can photograph it or whatever, and email me, and then it comes in as a possible thing you can claim on asthma-friendly schools as a point. But one thing we've seen in other programs where school nurses have completed this ASME, we've seen that the blue is the before. There were 39% of the kids who took that pre-assessment were uncontrolled. And after they completed just that few sessions, 25% were uncontrolled. So that's great improvement in control, a reduction in those uncontrolled. And then those who were educated in spacer use, there was 74% who used it properly, and after they were educated, 100% could use their spacer properly, and 64% could use proper inhaler technique before, and then it improved to 97%. So that's 30% improvement in those kids who are getting medicine to their lungs. And so let's see, I think we can just move on. We've known those impacts can reduce hospitalizations and other adverse impacts of uncontrolled asthma. We know it's effective. It's been tested. It improves knowledge. It improves skills, techniques for inhaler use. And we provide whatever support you need in terms of reviewing that, walking hand in hand with you over how to fill out the form, and answering any questions. We can help you nominate your school for asthma-friendly recognition. In this regard, we did remove the cash incentive because schools weren't finding it very useful, but we enhanced our recognition via an interactive map on our website and media announcements. So we oftentimes are featured in local news and media reports of what schools have been recognized for asthma-friendly. And so with that, I'll turn it over to Dr. Cowan for any content, but take a moment perhaps to ask any questions about the applied element. Any reactions, any interests, any, no, I'm not interested. Has anyone tried it before yet? Okay. Well, feel free to reach out to me if you're interested, if you need support. But I recommend, if you can think of one student before we meet next time that seems to have uncontrolled asthma, and you pull out that packet, and just begin to think, when can you see them? When will they come into your office, or can you get them in for 5 minutes, that 5 to 10 minute blast, and go ahead and start. And by the end of these rounds, you'll have done it, and it'll be pretty easy. But reach out to me if you need any supports. Dr. Cowan?
Hi, everyone. I'll start with this next piece about pathophysiology of asthma and just go through some of the context and teaching points around pathophysiology, really more as a background. I admit it's not the most exciting part of these discussions. I really enjoy more about the action plan and trigger reduction and some of those elements just of the daily asthma management and the medications and the devices. But this gives some context and actually what families think about too, and understanding how their medications work and why they take things is sort of the basis for that. This pairs up there's a video about pathophysiology. Again, it's not the most exciting. So often I find when I'm teaching, it helps like in shorter bursts using a diagram or a picture, and that's in some of the teaching materials. And I share on here what I use as well. So we'll start with the definition of asthma as a chronic inflammatory disorder of the airways with recurrent or persistent episodes associated with variable airflow obstruction, bronchial hyperresponsiveness to a variety of stimuli. And the NHLBI guidelines were updated in 2020 with some focused reviews around smart therapy, which we'll talk about later, things related to allergy management, and the 2007 guidelines still stand as the full guidelines, and part of the 10 key clinical activities for asthma healthcare delivery is to focus on routine education on patient self-management. So that's where we're focusing today on these teaching points. You can go ahead to the next slide. So that's what the overview of the clinical activities for healthcare delivery, one of those being in red there about the asthma self-management. Next slide. So this is the diagram I tend to use when I'm teaching. I'm not an artist. A lot of people draw this out for people, but this diagram I tend to use to help families understand what's happening in the lower airway and then how their medications work. And when we come to the discussions in the later sessions about medications, we'll come back to this diagram as well. But what's happening here is that have the airway, you have the windpipe, and you're branching like you're on the inside of a tree to the lower airway. And in these small airways, you have this wall here that the main problem here is the center one with chronic asthma, with persistent asthma, that airway is inflamed, and that's the problem. And then when there's a trigger, you get more inflammation, more thickening in there, plus the tightening of those smooth muscles around the wall. And you get air trapping in the alveoli. And that's where it gets difficulty when you can take a breath in and fill the balloon, but you can't exhale all of the air out. So you're filling your full balloon and you're trying to breathe on top of that, and you can't let all the air out. So kids get cough or wheeze or both when things are tight there. And some kids are living sort of like this middle one here. And that's commonly what we see with chronic asthma that's not well controlled. So when we're looking to treat with medications, we target the smooth muscles, so symptom relief to open that up with bronchodilators, and then we target, if kids have persistent asthma, then we target that inflammation to treat there. I do find that helps people know where the actual problem is with the asthma and where in the lung this is happening. And we'll come back to this later when we talk about medications. Next slide. So this is a clinical diagnosis. So it's based on the history. And in kids, it's not always straightforward. So that can be pretty variable, especially in really young children. It doesn't require measurement of lung function to make that diagnosis, since that's a historical diagnosis, but it can help. We do measure lung function in clinic, but you can make that diagnosis without it. And the episodic nature of it, the variety of triggers, that might make things trickier to sort out as well. And then the younger you go, in really young infants, the diagnosis often isn't made until at least the second episode or flare, because we want to see a pattern in what's happening. But based on the overall history, we may have a good idea what the risk factors are, even with the first episode. And also in really young children, there's a higher risk of other comorbid conditions like airway issues in infants. Next slide. Symptom with asthma can be cough, wheeze, shortness of breath, exercise intolerance, chest tightness, prolonged colds, recurrent pneumonia. The signs, there may be none. If they're not acutely having symptoms, the exam can be totally normal, may not have any symptoms at the time. If they're acutely ill, they may have fast breathing, wheeze, decreased air movement in the lungs, retractions, prolonged exhalation, and increased AP diameter of the chest. And that prolonged expiration, increased AP diameter of the chest is from that air trapping. So when you're able to breathe in the air, but not exhale fully. The differential diagnosis for asthma, sometimes it's pretty straightforward, but we consider those other issues too that can complicate things, like is this just infection? Do they have recurrent or chronic aspiration, CF, dynamic airway collapse, foreign body, vocal cord dysfunction, hypersensitivity, pneumonitis, or other issues? And the natural history of this is variable as well. For most people, this begins early in life, though it's not uncommon for us to see this first present in teens. But most who do wheeze before age 3 don't go on to keep having symptoms through childhood. The early life wheezing is pretty common in infants, but not everyone goes on to have persistent asthma. The risk factors are allergy, eczema, recurrent wheezing, and parental history of asthma. There is an increased risk for prematurity and increased risk of tobacco smoke exposure. And some of the early exposures may make a difference. We see with the hygiene hypothesis, so early endotoxin exposure might preserve a Th1 response and avoid switching to a Th2, which is an allergic response that makes kids more prone to asthma. Common triggers, they probably see a lot at school, the viral infection, and then environmental exposures like tobacco smoke exposure, wood smoke, exercise, pollen, ferret animals, air pollution, airborne chemicals or dust mites, mold, past changes in weather, strong emotional expression, menstrual cycles are among the more common triggers. Next slide. Well, let's touch on viral infections here, because this is something that we all experience a lot with the kids. And so these do predispose some kids to developing asthma and trigger exacerbation. So rhinovirus is a pretty heavy trigger for kids with asthma, especially kids who are predisposed and already have risk factors. RSV is a risk factor we commonly associate with recurrent wheeze in infants and young children. There's an increased risk with asthma with a family history, but it doesn't tend to be associated with wheezing as kids enter later childhood and adulthood. A non-RSV infection in early life is associated with an increased risk of wheezing recurrence. So kids with rhinovirus or rhinovirus bronchiolitis early in life, that's a significant predictor for asthma in school age. And then when we say in school age kids, little kids, school age kids, why are kids so sick during the cold season? Airway hyperresponsiveness remains pretty high after a single cold, particularly.
Dr.
We
Cowan,
can back up one slide, please.
There we go.
Do you have the slides, Karen? Can you back up one slide, please?
Can you see my slides?
I can. Could you back up one slide, please?
Sorry.
Yeah. So with viral infections in school-age kids and young children, the reason we see kids having so much trouble during the cold season is the persistence of airway hyperresponsiveness after a lot of viral infections. Sometimes colds are just a cold, symptoms in the nose, but colds that can trigger asthma symptoms can lead to airway hyperresponsiveness that lasts from weeks to months. And after several colds, the airway hyperresponsiveness can remain elevated for over 6 months. So we do see kids getting in trouble in the cold season after these back-to-back colds. So that's why we've often focused on more aggressive treatment during the cold season for kids who have these risks. And do you think that prolonged virus-induced airway hyperresponsiveness in allergic kids can contribute to asthma persistence as well? Next slide. So when we're looking at kids in clinic with asthma, a lot of things are pretty commonly comorbid with asthma. Not everyone has allergies who has asthma, but some people do. So working on minimizing those triggers, deciding on when they need an allergy referral or testing, then focusing on environmental exposures like smoking, and then air quality exposures like we've had. And then other comorbid conditions or things that can be confused with asthma causing similar symptoms, we do think through those and just, do they have more than one problem, or are we, concerned about something else happening? Next slide. Now we're moving into discussing some testing things. So this is examples of how asthma is clinical diagnosis. So things like we can't diagnose it by an X-ray. We often do X-rays to make sure we're ruling out something else. So if we're worried about pneumonia, some anatomic things that might be seen on an X-ray, those type of things we do look for on X-ray, but it doesn't give you a diagnosis of asthma. So for example, either of these films, the child on the top two or on the bottom two, these are films that can look like asthma. So you can see on the pictures on the right, the diaphragms look a little flat, a little bit hyperinflated. But we see the same thing with asthma as we would with someone who had chronic aspiration or cystic fibrosis. So you can have, there isn't a specific pattern on the X-ray. Next slide. And then we do other testing as well. I have starred here the main test that tends to be helpful is spirometry and the protected FEV1. This is really reliable. The downsides is you need someone who interprets these frequently to make this helpful, and you need someone who does the testing often, and that tends to be some offices do this or a larger pulmonary function lab like we do at the hospital. Other measurements, you may be familiar with peak flow devices. That we don't tend to do as much. They're a little hard to come by actually anymore, since we don't recommend them as much. The downsides are a little effort dependent, and that you consistently need to repeat the measurements over time. So this is something where you can have someone blow into the device twice a day, see how much they can breathe out, see if they're at their best. And it can be a good way to track someone who has poor symptom perception, gets sick very quickly, to help with their management. But the downside is you don't want that to detract from them taking their maintenance therapy, doing those other things. And it really tends to be that type of problem with using this rather than the gains. And if you're not doing it regularly, just doing it one time during an exacerbation really isn't going to tell you a whole lot about it, because you'll probably already know if they're sick or not. But it is something, can keep in the back of the mind for kids who are harder to manage symptoms, that this might be for some select families a helpful tool. Another test that we use sometimes is a fraction of exhaled nitric oxide. That's more expensive test to do. It's in a specialized lab. And that number can predict steroid responsiveness in kids with allergic asthma. Not as a helpful for non-allergic asthma, but it is an add-on tool that we use sometimes. Slide. So go back to our main tool for testing of spirometry. So there's more pictures of what the normal airway looks like on the left, and then as the airway on the right. And you can see that obstructed airway, you can see smooth muscles that are clamped down on the one on the right. And that, when you take a big breath, this is what the flow volume looks like when we interpret spirometry. So you take a big breath and you get that triangle shape. and that slope down is when you're breathing out. And when the airflow is normal, like on the one on the left in the blue box, it just looks like a triangle. On the right, it looks like more of a slope. And then you can see that once you then pre-bronchodilator and post-bronchodilator, those graphs on the bottom, that improves after albuterol. That would be a really classic pattern for asthma, particularly someone with uncontrolled asthma or someone who's having an exacerbation. I will point out that most kids do have normal lung function when they're not having an exacerbation. So when we see kids with a asthma history and normal lung function, we still will go by symptoms, and not only the lung function. So we would never say you don't have asthma because your lung function is normal today. We would still put the whole picture in context. But it can be really helpful because the history and physical can't always reliably characterize the degree of lung impairment. So I can't always guess by what the history is, what the spirometry is going to look like. Next slide. We also classify severity of asthma. So what that is, that's the intrinsic severity of disease, and that can vary over time. We measure that most directly by the history at the initial presentation that guides treatment decisions, meaning what types of medicines to use for maintenance. And then once kids are on therapy, really correlate that with what the lowest level of treatment is to remain under control. And so severity can change over time. And I think the important thing to remember here, the main point would be is severity might not correlate with intensity of exacerbations. We have a good number of kids with severe persistent asthma that certainly if they were not on a good solid regimen of maintenance therapy, that they would be at risk of a severe exacerbation. But a lot of those kids do not have severe exacerbations because things are so well controlled. It just may take a higher level therapy, and that is why it would be classified as severe. And then we do have some kids with mild or moderate persistent asthma, and you can have a severe exacerbation, even if your asthma is considered mild. Sometimes that's a bit of bad luck, sometimes it's asthma control, sometimes it's the environmental factors around. So just because they have mild asthma doesn't mean they can't have a severe exacerbation. And then we think about domains of severity and control would be impairment. We want to reduce impairment. So like Karen mentioned, kids, half of kids not being able to do what they want exercise-wise. We want to reduce the frequency and intensity of symptoms and functional limitations. And then risk-wise, we want to decrease the risk of exacerbations, the risk of decline in lung function, risk of reduced lung growth, and then the other side of risk is adverse medication effects. So we do want to follow closely for kids on medications that they're not having side effects or managing those so that they don't have those problems. And then the next 3 or 4 slides, we're not going to go into these in detail, but I wanted to share what's out there in terms of how we classify severity and deciding on treatment. So basically, the easiest way to divide up is deciding whether they have persistent asthma, meaning they need daily maintenance treatment, or intermittent asthma, meaning they need bronchodilators as needed. And this does help to decide that. That's a lot of stuff we do by clinical experience that consolidate this information and be able to assign that easily. But there's actually the data say that you can go to these charts, and when we're looking at asthma control, deciding the most severe amount of impairment and risk, and then marching that over there to see, well, how many times a week are they using a bronchodilator for symptom relief? How many times are they waking with cough? And then march that over to the age and be able to classify severity, and that helps guide starting treatment. Next slide. And then there's these graphs for different age groups of children. And when you have infants and toddlers and young preschoolers, we don't have lung function for them. So that'd be purely symptom based. And as kids get older, we can incorporate the lung function. We can just move past these. Okay, so asthma control, be the degree to which the manifestations of asthma are minimized and the goals of therapy are met. So are the symptoms reduced? And then what are the goals of treatment, are those being met? So are they able to exercise, do the sports that they want? Is quality of life better? Are they sleeping better? Are they at less risk of exacerbation? And we assess control before starting medication, but then the emphasis on maintaining that and then stepping up or down treatment based on how the control has been and how long things have been going well or not going well. Fine. So there's a lot of factors that affect adherence and control. Most of these are more social factors of the environment that the child is in. And depression, stress, anxiety in the family or the child can contribute to poor control. Tobacco or other substance use history, safety in the home, food security, multiple homes or caregivers. And that can be knowledge level of various caregivers, but it can also be whether there's an appropriate level of supervision, and then do they have medications where they are. We have found, and we'll probably be talking about this quite a bit in the next session about devices, that there's a lot of barriers to obtaining medications, and that has been much worse lately. People are having a lot of trouble with this due to what insurance is covering. Even before that, the cost of medications on a lot of plans is very expensive. Transportation to get to the pharmacy, if they're waiting for something approved, they have a ride today, but they don't have a ride once it gets approved. Are they getting enough refills? And then the pharmacy issues, there's a lot of the cyber attack, those things have been just kind of barriers that have been piling up for families. And I think the insurance barriers have just been really hard to overcome for a lot of people. And then the clinics are really strained in terms of trying to get medications for everyone. And even knowing who has medications, we are seeing as a lot of kids running out of things, and then there's a gap in their treatment even when they have been doing really well. And I have to say that's probably been the main issue lately, is that kids who are doing well, who are off therapy, who are at risk waiting to get something. Schedule for medications, that's something we work on a lot. And then when there's changes in the home environment, who's taking care of them? Is there just a change in how people perceive the supervision need to be? How families feel about medications? Do they feel comfortable with it? Are they worried about side effects? Are there things that families need to understand better, or how can we help with that? And then sometimes when some of these factors lead us to think about, for some kids, whether, if any, medications need to be administered at school. And sometimes offering this to families helps a lot when they can think through, is that going to help? And there's a lot of families who are very grateful for that, and it's really been life-changing for them to see the kid doing well, getting things. For some families, it's been just a relief and thing that off their plate. And for some families, that's actually been like quite a motivator for them to realize their child's need to take their therapy. Other pieces is checking the medications and devices. We'll look at some of the devices next week too, because there's been a lot of different devices out there that kids haven't used before. So we'll review how to go over those techniques. And then are they using their spacer still? If they have a device with a spacer, are they using that? Sometimes that falls off the radar as something you need to do, or they lose it. And then we often do check in our clinic, we'll check the refill history, because that may help us know that if they're getting what we think they are. It's not always perfectly accurate, but it's pretty helpful to know if they are getting enough, or if they're getting what we think they are. Next slide. Karen shared the slide before about risk factors for uncontrolled asthma. Uncontrolled asthma would be a risk factor for worse exacerbations. And these factors here are what we worry about for higher risk of exacerbations or death. So severe airflow obstruction on spirometry, ED visits or hospitalizations in the past year, history of intubation or ICU admission, certain demographics, and that does include kids who have uncontrolled asthma who are not on inhaled corticosteroids, psychosocial factors, and then attitude beliefs about taking medications. I think I'm going to turn it back over to Karen.
Thank you, Dr. Cowan. I think before we go on to just doing some conversation about the applied part, perhaps we'll open it up to some questions on any of the clinical elements that you presented on, or if anybody's facing some issues in their school nurse office or other offices. Any questions for Dr. Cowan or anyone else?
Can share or put in the chat, and then I'll put my email in the chat as well. So if there's certain questions that you think of that you'd like us to circle back to in the next session, or just reply to, I'm glad to do that.
Yeah, one question I had was just to hear if any of the school nurses or anyone else has been having difficulty with this discontinuation of flow vent, and how many students are being impacted by that. That'll probably be more of a conversation for next week, but and the other issue is Kelly and or Melissa, at the beginning we didn't quite catch in the recording, so I'm putting up the title of today's presentation, and then maybe you can state a little bit more about the continuing education credits, and any disclaimers. That one got cut off. So if they want credits, they should, or need instructions, they should put their email into the chat, and and those will be available soon. Is that right, Melissa?
They're available now.
Oh, okay.
I don't know how to attach it. I sent it to you, Karen. Like,
Okay.
It's like the directions. I don't know how to, like, it's kind of two things, but I could.
Go
If you
ahead and
have their
just send it to
emails.
me, and I can send out to those who put an email in their
Okay.
chat.
It's easier because it's like a full email
Yeah.
if we could just forward it on. And there's
Yeah,
a
I can do
question
that.
in there about our spacers covered if they break it. I think we can get them every 6 months for our new ones. And oftentimes you can write, so they should be able to get a new one for sure. Because they should have one at home so they can cycle the old one to you, and then the family should go out and get a new spacer from the pharmacy, and we can always write new ones. And then and we've talked about this before, is that you can always use corrugated tubing, like trach tubing, and you can get it off of Amazon for like $6 for like a whole roll. And so that's often kind of what we've told some of the nurses too, to have kind of spacers on hand if you're always having some that not have them or whatever, and it comes in a whole roll, and there's like little spots where you cut it, and that can be their spacer for the year. So that's another way to work around that, but they should also be able to get a new spacer. Sometimes primary cares have extras to hand out. We hand them out. We don't always have them because they get handed out so fast, but it shouldn't stop them from getting a new one. That helps that question.
Some of them are, the pharmacy copays are really high with some insurances, and families sometimes have found different tips, like at some pharmacies they can get 2 for $50 rather than $60 a piece, depending on the type. And Amazon also sells those as well. It still seems a little pricey to me, but it's a lot cheaper sometimes than insurance. I think my insurance has a $60 copay for one, where I could buy that for like $10 somewhere else. And so that sometimes has come up as a barrier to people, and we've troubleshooted that way, whether pharmacies have other suggestions of that, and then or purchasing it elsewhere. And then that tubing that Melissa mentioned is fantastic. Some of the inhalers, you have to maneuver it a little bit to jam it in there, but it works really great. And some kids you may see have those, especially older kids have like those for sports because they fit in the pocket. It's not so bulky to carry around, and those are certainly fine for the office.
Another example I heard from I think it was Dr. Kaminsky, was to take like a small water bottle, and you cut the flatter the bottom, the better, but you cut to the size of the inhaler and squeeze it in here, and then you take the lid off, and it becomes a spacer this way. And there are even smaller bottles, but I haven't tried that, to see, and you need to make sure the tight fit, but it's a good alternative solution as well. Other questions? I know that at the beginning, yeah, any questions? I know in the objectives, I'm just going to share the screen again. We talked a little bit, and Melissa started us off with a highlight that, you know, you get additional, you can get your continuing education credits and add your email in there, and we'll send you those instructions for how to access those and claim them. But in addition to that, you can also look to get credit for attending and completing these Ask Me sessions, this network of a series, and through the Asthma Friendly School Recognition Program. And then also, if you were to try to deliver the packet, that's Ask Me in Schools packet, you can get credit for that. And later, when we talk about triggers, we'll talk about the Envision walkthrough is another best practice, which you can get credit for. And before the end of, before we meet again, I hope you can try to identify at least one student with uncontrolled asthma, and then, take a look at that packet and determine how you might deliver those little blasts of content in those 4 areas, including the basics, medicines, triggers, and management, asthma management. And then if you have any trouble, reach out and then fill out that form and get it to me. And you can get additional credit to be able to nominate your school for asthma friendly school recognition. And we'll go over that at some point. Any other questions? We're getting close to the end of the time. I just want to make sure there's opportunity for you to share or share of any current challenges you're facing, any hot topics, hot concerns going on in your offices. Is there a lot of asthma issues are you facing? Or are you seeing other, not so much yet, huh? Okay, no further questions. Then I appreciate the presentations you've made, Melissa and Dr. Cowan. And any last comments, either of you? Any words of wisdom? All right. I know Dr. Cowan has put her email in the chat. Please provide your email if you want those packets, and we'll get those instructions to you for getting access to the CMEs. We'll have time for that. And we look forward to seeing you next Tuesday. Send in any questions you might have or topics of interest, and we'll try to make sure we weave that in to address. This should be something that allows you to bring issues or topics of concern or areas of, needing support. This should be a meeting that provides you valuable information and support. And I wish you a great day. Thanks so much.